Thank you very much for your introduction again. I will be covering some of the topics that Dr. Apostolidis has already mentioned in his talk, but I'm going to review how can we improve the outcome in high-risk disease in diffuse large B-cell lymphoma patients. As a general overview, and already mentioned before, we have had a new update in the WHO classification just published 2 years ago in 2016. And diffuse large B-cell lymphoma remains the most frequent non-Hodgkin lymphoma subtypes that arises around 37% of all of mature B-cell lymphomas. As already mentioned in my previous talk, the median age at diagnosis is around 66 years of age, and the diagnosis is increasing with the aging population. So far, in order to identify the high-risk population, we could only use clinical factors like the International Prognostic Index, the IPI. And as you already know, the prognostic factors included the age, the performance status, LDH, advanced stage, and more than one extranodal lesions. And we can classify patients into 4 different risk profiles into low intermediate, high intermediate, and high risk factors. But if we pay attention to the prognostic factors, 2 of them are patient-related, and 3 of them are disease-related. But so far, we do not have any lymphoma-related prognostic factors that we can use in order to give a more accurate prognosis in our DLBCL patients. So how can we define nowadays high-risk patients? We can develop new prognostic indexes. I'm going to review with you 2 of them. We can check or assess for the cell of origin. We can assess for the BCL2 and the role of c-MYC rearrangement in the formerly known double-hit lymphomas. Now in the new update classification of the WHO, it has been changed. And of course, it's also of high risk, those patients that are at risk of CNS disease involvement or even relapse. What about prognostic indexes? We have already mentioned the classical IPI, and now we have 2 new proposals, the NCCN IPI and the Spanish IPI, the HELSAMO IPI. And in this study, these authors have compared all these prognostic indexes. And as you can see, in both NCCN IPI and HELSAMO IPI, there are more age subgroups in comparison with IPI. So the age is going to matter a lot in terms of prognosis in our patients. And for the very first time, another lab test like beta-2 microglobulin is going to be incorporated in the HELSAMO IPI. And in the NCCN IPI, we have more levels of LDH levels above the upper normal of limits. And if we check in the same population the 3 different prognostic factors, you can see that both NCCN IPI and HELSAMO IPI classify better diffuse large B-cell lymphoma patients according to risk, because in the Kaplan-Meier curves, the curves are more separated than in the IPI, in the classical IPI. And the HELSAMO IPI, the Spanish one, identifies better a subgroup of patients with high risk with a very poor prognosis, as you can see in the Kaplan-Meier curve, with a very low overall survival. So what strategies have been explored to overcome this poor prognosis in the high-risk patients? We have tried to reduce the interval between the chemotherapy regimens, also named dose-dense regimens. We have compared RCHOP 14 versus RCHOP 21. We have explored the addition of new drugs like Etoposide in the regimens like RCHOEP. We have explored more intensive regimens like RMegaCHOEP or RMegaCHOEP. And we have explored high-dose chemotherapy frontline in patients achieving first complete response. We are going to review briefly all of these studies. If we compare the dose-dense regimen RCHOP 14 versus RCHOP 21, we see that at the end, the overall survival at 2 years was almost the same in both groups in these two trials, in the Cunningham one and in the French group. And in the update of the study published by Cunningham with a longer follow-up of 46 months, the 2 years overall survival and progression-free survival was almost the same. And they didn't find any differences, neither high IPI nor high-risk molecular markers like cell of origin. So we couldn't find any subgroup that could benefit from this dose-dense regimen. What about the addition of new drugs like Etoposide? In this study published by the German group comparing RCHOP versus RCHOEP, again, no differences between RCHOEP versus RCHOP among the entire cohort, and also in the favorable and also in the unfavorable risk patients with similar complete response rate and 2 years progression-free and overall survival. What about more intensive regimens? In this study, also published by the German group, it was compare RCHOEP versus a higher intensity regimen like RMegaCHOEP, and again, the 3 years event-free survival seems to be the same, and RMegaCHOEP was not superior to RCHOEP, and also it adds more significant side effects. And what about the role of using autologous stem cell transplantation frontline? We have one clinical trial by the Goelam's group in which it was compared CHOP 14 versus rituximab plus high doses of chemotherapy followed by autologous stem cell transplant, and again similar overall response rate and similar 3 years overall and progression-free survival. And in the right side of the slide, I want to share with you two retrospective studies with an increase in the 5-year overall survival in the Irano trial, but in the second one, in the trial published by League and collaborators, you can see in the Kaplan-Meier curves that we didn't find any differences regarding the IPI. So again, using frontline high doses of chemotherapy plus autologous stem cell transplantation in high-risk patients is not going to improve neither progression-free nor overall survival. Regarding cell of origin, I'm going to go very quickly because Dr. Apostolidis has already covered this topic. And I want to highlight some aspects. The first one is that cell of origin is going to impact in the prognosis not only in high-risk patients, but also in low clinical risk patients identified by the classical IPI. You can see that patients with germinal center B cell subtypes are going to do better than patients with activated B cell lymphoma. And as already mentioned, try to identify the cell of origin by immunohistochemistry by these two algorithms has not 100% of concordance, so it is recommended not to tailor therapy according to these immunohistochemistry approaches, and only they can be explored inside clinical trials. This cell of origin is going to predict the outcome, not only in first line, when patients are receiving RCHOP. You can see again that patients in the germinal center B cell subtypes are going to do better when treated with RCHOP frontline in comparison with activated B cell lymphoma subtypes, but also in the relapse setting. And this is a very relevant work. If you see that if patients are going to be treated with a regimen like RIs, the outcome of patients with any of the molecular subtypes are going to be the same, with a 3 years progression-free survival around 30%, but patients with a germinal center B cell lymphoma subtypes are going to benefit to receive a second-line therapy before autotransplant with a regimen with a high-dose cytarabine like RCHOEP. So in our institution, as we do not have the gene expression expression profile to classify patients according to the results just published, we decide to use RCHOEP in order to improve the outcome of patients with the germinal center B-cell lymphoma subtypes previous to autologous stem cell transplant. And already mentioned by Dr. Apostolidis, the cell of origin classification was done by gene expression profiling, and in order to translate into the daily clinical practice, there is this platform which can be done in formalin-fixed paraffin embedded tissue, and it replicates the results, and again, it has a prognostic factors. Patients with germinal center B-cell lymphoma subtypes are going to do better in terms of progression-free and also overall survival. How can we overcome the poor prognosis of ABC diffuse large B-cell lymphoma subtypes? There are explored many attempts with the addition of drugs to the gold standard, which is RCHOP. As already mentioned, it has been explored bortezomib, ibrutinib, and lenalidomide. This is a meta-analysis where all trials that explore the combination of bortezomib plus RCHOP, and in some cases with RCHP, avoiding vincristine in order to reduce the neurotoxicity of the combination of vincristine plus bortezomib. In this meta-analysis, you can see in the entire cohort that we are not going to see any benefit of the addition of bortezomib in both progression-free nor overall survival, and in the entire cohort, and also in the non-germinal center B-cell lymphoma subtype. So bortezomib is not going to be the drug in order to improve the outcome in these high-risk lymphoma patients. Already mentioned, there has been a press release by Pharmacyclics 2 months ago explaining that in this Phoenix trial, the investigator didn't meet the primary endpoint, and probably in this ASH meeting in San Diego, we will have the final results of this study. And we are still waiting for the final results of the robust study, where in ABC lymphoma subtypes identified by the gene expression profile using nanostring technology, only in these activated B-cell lymphoma subtypes, patients were randomized to receive RCHOP times 6 versus RCHOP 21 plus lenalidomide in a basis of 15 milligrams Q-day for 14 days. But results are still pending, so probably in the next ASH meeting we will have the results of this trial. What about, and now we are moving to another field, the BCL2 and the role of c-MYC in identifying high-risk patients. As you already know, c-MYC in all of our trials reported has an adverse impact in overall survival, and it can be identified by rearrangement in around 10% of diffuse large B-cell lymphoma patients. Again, this has to be done by FISH in order to identify the rearrangement, but in order to do it more easily, and because FISH analysis is not already available in many pathology labs, these authors made an attempt in order to identify this double hit, formerly known double hit lymphoma, using an immunohistochemical staining. And in the bottom of the slide, you can see that they replicate the data about the poor prognosis of double hit lymphoma. In the line curve, the outcome is going to be worse than patients not harboring this double translocation. And using the immune histochemistry score, patients with double staining of BCL2 and c-MYC are going to have a poor outcome, and these patients are going to be known as double expressors. But we have to think about if there is any relationship between cell of origin and MYC and BCL2. And this is a very elegant work published 3 years ago. And if you see here are patients analyzed by FISH, and if you see in the column of germinal center B-cell diffuse large B-cell lymphoma, almost all 100% of the patients with double hit lymphoma are in the germinal center B-cell lymphoma subtypes, and we are not finding any double hit lymphoma in the column of activated B-cell lymphoma and in the unclassified diffuse large B-cell lymphoma. But if we pay attention to the double expressor analyzed by immunohistochemistry, you can see in the bottom of this table that dual expressors are going to be present in all of 3 lymphoma subtypes, but is going to be enriched in the column of activated B-cell lymphomas. So probably the worst outcome of double expressors is not related to the overexpression of MYC and BCL2, but is related to the cell of origin, like in this case, because they are, in most of the cases, activated B-cell lymphoma subtype. So both cell of origin and MYC and BCL2 immune histochemistry both contributed to a specific risk stratification in diffuse large B-cell lymphoma patients. And how can we treat these formerly known diffuse large B-cell lymphoma patients? Dr. Freidberg discussed 2 years ago in the ASH meeting and in this publication in Blood. Now this entity has to be called as a high-grade B-cell lymphoma with MYC and BCL2 translocation in order to distinguish with the double expressors. There are no randomized trials in this subgroup of patients. This is a very interesting retrospective study conducted at the MD Anderson Cancer Center in Houston, Texas, and RCHOP seems to be not the best option for these double-hit lymphoma patients. And EPOC plus rituximab in a dose-adjusted basis seems to be the best regimen, albeit randomized clinical trials are needed because this is a retrospective study. And in this same retrospective study, they analyzed the role of autologous stem cell transplant in first complete response. And again, it seems that there is no role for high doses of chemotherapy followed by autologous stem cell transplant in first complete remission, despite the poor prognosis of these double-hit lymphoma patients. And finally, to conclude, I want to give a few words about the risk of CNS disease. There is also a prognostic index called CNS IPI, and if you see the prognostic factors, there are all the factors that are included in the IPI, and also it is included the kidney and adrenal glands involvement. And in the right-hand side of the slide, you can see the risk of CNS relapse according to the number of prognostic factors in this CNS IPI. And following with this, the Spanish group of lymphoma has developed these guidelines published last year in Hematologica, and we assess for these risk factors for CNS involvement. And they are an elevated LDH plus more than one extranodal site, or involvement of the following sites: testis, breast, and epidural space, and also, of course, the kidney and adrenal gland that was included in the CNS IPI. Again, if a patient has a high CNS IPI with a score above 3 points, or if a patient is a formerly known double-hit lymphoma with MYC and BCL2 or BCL6 rearrangement. If a patient is considered to be at high risk of CNS disease or eventually relapse in the CNS, we proceed to the CSF examination by cytology and also by flow cytometry. If both are negative, we give to these patients CNS prophylaxis with methotrexate, and if one of them is positive, we give CNS therapy in this subgroup of patients, as already mentioned in the previous talk. So with this, I want to conclude with my take-home messages. In future prognostic indexes, we should incorporate factors related to lymphoma biology, not only factors related to patient-related or disease-related. The cell of origin is going to predict outcome in diffuse large B-cell lymphoma patients that are going to be treated frontline with RCHOP, but also in the relapse setting. Formerly known double-hit lymphomas are more often in the germinal central lymphoma subtypes, and double expressors are going to be found more often in activated B-cell lymphoma. In both cell of origin and MYC and BCL2 rearrangement is going to contribute to a specific risk stratification, and the risk of CNS involvement should be assessed in all high-risk patients. So I want to conclude with this. Thank you very much for your attention.